Welcome to the 5th CSO Virtual Experience webinar. We are very pleased to have you here today. Our expert panel of ophthalmologists will share their experience using CSO device in the clinical practice. We are very pleased to present the new Sirius Plus for the first time, as well as our other products. We believe our mission is to continuously update you with the information concerning the clinical application of the product. Unfortunately, in this crazy pandemic period, it seems this is the only way to stay in touch. Everyone at CSO truly look forward to meeting you again in person soon. We are always available to support you and answer to your questions concerning CSO products. Just connect to the CSO website and book an appointment with one of our product specialists. We thank you again for the time you are spending with us. Please keep safe. Now, let me introduce the first speaker, Dr. Francesco Carones.
Good morning, good afternoon, good evening. It is a pleasure for me to present you a new system, a new platform that will help us quite a lot in having a better understanding of the anterior chamber. The Sirius Plus, which has to be considered the evolution of the Sirius instrument that we all already know. I have some financial disclosures to state. I'm a consultant for CSO Italy as well. So let me start presenting you what is new with the Sirius Plus. This is a very, very, very nice technology that I think is going to replace all the other pre-existing shine flow cameras. The Sirius Plus comes from the older brother, the Sirius instrument. So it has the same features, but all of the same features have been implemented. So as you will see in a while, the topographic maps and summaries have been improved, as well as the pupillography has been made easier and with more information. Now it is possible to have an evaluation of the fluorescein analysis, and it is also possible to see the lipid layer on the tear film. Besides all of that, the Sirius Plus has some very nice additional features to perform a complete workup for the anterior surface, especially as regards the tear film analysis and the ocular surface status, as my associate Luca will present you in a while. Let me start from the technology, because as well as the Sirius, also the Sirius Plus involves two different technologies, a shine flow camera to provide elevation and thickness data of the whole anterior segment, and a Placido disc-based topography with an arc step algorithm to provide the reconstruction of the anterior curvature and all refractive powers from the anterior surface. As I was telling you, the high resolution color camera of the Sirius Plus, as well as the new completely re-engineered optical path, allows a much better imaging of the anterior segment. As you can see here, on the top is the Sirius, on the bottom is the Sirius 1, and I will go a little bit more in detail in a while. So the Sirius used to have a 25 anterior segment scans per acquisitions with a lot of data points. The Sirius Plus comes with an analysis that can reach up to 100 anterior segment scans with a much larger number of data points to generate all the information that we need as regards the anterior segment. And as I was already showing you, here is an evaluation of the same eye measured with the two different systems, the Sirius and the Sirius Plus, on the bottom, and you can see how, for instance, the scatter of the light with the Sirius Plus is much lower than with the Sirius. You can see how the details as regards the cornea are much better with the new Sirius Plus, as well as all the details of the crystalline lens. And again, this is thanks to the high-resolution color camera, as well as the new optical path completely redesigned. The maps that the Sirius Plus is able to generate are similar to them from the Sirius, but all of them have been improved. So we can measure the anterior and posterior corneal surface as regards the tangential and axial curvature. We can have a measurement of the anterior chamber depth and the elevations of the anterior and posterior corneal surface. We can measure the refractive power of the anterior, posterior, and total corneal curvature. And we can also measure the corneal thickness all over the entire dimension, all over the entire area of the cornea. This enables the system to plot very nice new summaries, as the Keratoconus Summary, that I will go back in a while, but also other summaries like the IOL Summary that allows to have a better understanding of the astigmatism, as well as a better positioning of the toric IOL. We have also a Glaucoma Summary to better measure the anterior chamber and the risk for glaucoma. We also have a summary for those who are implanting the intracorneal ring segments to have a better understanding and a better planning for this kind of surgery. And we also have a Zernike summary to have a report on the high-order aberrations coming from the cornea. Here is the Keratoconus report we used to have with the Sirius. Very nice, pretty detailed. But if you can compare the previous image to this one, this is the report that we have on the same cornea with the Sirius Plus. So many more features, many more analysis. So we can analyze the anterior surface as regards the different curvatures. Also, we have a comparison between the elevation versus the normality for the anterior surface, for the posterior surface as well. We can measure all the thicknesses, also the pattern deviations of the thicknesses. All of these for giving a better understanding and being able to detect those cases with mild or form first keratoconus. It is possible now also to measure the enantiomorphism. We can have a bilateral summary. So again, this report has been improved quite a lot. With the Sirius Plus, we also can measure in a more accurate way the pupil size, scotopic, mesopic, photopic, but also dynamic, and the change from the black and white camera that the Sirius used to involve to the new high-resolution color camera that the Sirius Plus has allows many more features. As you can see here, for instance, all the features of the Sirius have been obviously implemented in the Sirius Plus, but detailed in red. Now the Sirius Plus, thanks to the new camera, can give many more information, much more information, many more options to have a better understanding of the anterior segment. Here is an example, for instance, for racing analysis. This is something that you can do only if you have a color camera, and this can be very useful in many situations, also to have an understanding on the epithelium. And there are many more options as regards the tear film analysis, as well as the ocular surface workup that my associate Luca Vigo is going to present in a while. In the meanwhile, I thank you for your attention, and I'll leave the microphone to Luca. Thank you.
Good afternoon. First of all, I want to thank CSO for inviting me to share this presentation with my friend and colleague Francesco Carones. Back to the future. Back because we are talking about Sirius. Future because we are talking about Sirius Plus, an evolution of Sirius, evolution in dry eye patient evaluation. We all know Sirius for cornea evaluation and for presurgical patient screening, getting accurate and precise data. Revolution Sirius Plus is able to examine ocular surface and tear film. In fact, we know that almost 20% of population suffers from dry eye disease, and the majority of these patients suffers from evaporative dry eye disease with meibomian gland dysfunction. Sometimes these patients have no symptoms, and so I think that it is very important to check tear film and ocular surface in all pre-op patients and not only in symptomatic dry eye patients. Dry eye patient screening allows us to have more precise preoperative data and better outcomes in case of anterior segment surgeries, and a specific and more effective therapy in dry eye symptomatic patients. These are the exams that are important to evaluate tear film. NIBUT, not invasive breakup time, gives us an information about the quality of tear film. The longer it remains on the ocular surface, the better it is for a healthy cornea and conjunctiva. Meibography is strictly correlated with meibomian gland dysfunction and the production of the lipid layer, and so it is associated also with tear film stability. Tear meniscus height in place of Schirmer test may be alterated in case of lacrimal gland dysfunction. Staining test with fluorescein shows if there are some suffering or damaged areas on the cornea or conjunctiva. Osmolarity test. The value of osmolarity is very useful to share dry eye patients from not dry eye patients with other not specific symptoms. Sometimes, in case of asymptomatic patients with high osmolarity, may be also predictable of worsening and associated with alterations on the ocular surface. Inflammatory test and bulbar redness are important to detect chronic inflammation and helpful to decide the therapy and to monitor the results. Questionnaire, for example, ocular surface disease index by Allergan, is very important to understand the severity of symptoms and the subjective impairment of the patient. These are the exams provided by Sirius Plus, and we will see one by one each of them. NIBUT. A map of the tear film is represented with the ruptures and their timing. We can see the instantaneous ruptures and the on average timing and the location of the tear film breaks. Looking at the curve, we also have data about the stability of the tear film. This is an example of bad tear film where there is a first rupture after 3 seconds and the tear film is not stable on the ocular surface. In this other case, we have a stable and normal tear film with homogeneous map and no ruptures during the 17 seconds of video acquisition. Tear meniscus better than Schirmer test because not correlated to corneal sensitivity. It is very easy to detect the tear meniscus height putting 2 points at the top and the bottom of the tear film. We can measure the tear meniscus in one single point, or we can get different measurements in case of irregular eyelids margins and consider the on average result. Meibography. We can get high definition images through an infrared camera placed in the head of the Sirius. Once we have captured the image, we can decide the area that must be analyzed, and immediately we have the value in percentage of meibomian glands ROS or not working. In this example, analyzing the eyelid, we found good glands with only few of them with not linear shape or light dilation. If we look at the classification scale on the left, we can classify this meibography like normal. Using blue light LEDs placed in the instrument and fluorescein, it is possible to see if there are some suffering or damaged areas on the cornea or conjunctiva. With a filter positioned in the head of the instrument and hiding the placid rings, we can also check the lipid layer. Looking for colored fringes or if the tear film is whitish or transparent, we are able to suppose the thickness of the lipid layer. The thicker it is, the whiter it is, and the better it is for healthy surfaces. OSDI questionnaire. After the patient has filled out the questionnaire, we can put the result inside the device software. Bulbal redness and its scale on the right, combined with inflammatory test, give us an important information about the presence of inflammation and its severity. Once we have done all these exams, we can put the results in a report file and we can print or save to compare it with different timing examinations. In this report, we have all the values got through the instrument and some other, like osmolarity, obtained with different devices, but then can be useful to reach a precise diagnosis. In this specific case, the combination of all the results allows us to make a diagnosis of severe evaporative dry eye with meibomian gland dysfunction. In this other case, we have only a light or initial dry eye. In conclusion, Sirius Plus is a complete instrument that provides accurate and precise data about anterior segment and tear film. It is very easy and fast to use, and the results are precise and repeatable. In our clinic, we use it for all pre-op patient screening and to monitor patient improvements after a specific pharmacological or instrumental therapy. Thank you for attention.
Good evening, everybody, and I'm very happy to be part of this symposium tonight. I was asked to moderate the session the presentation that was just given by Dr. Carones and Dr. Vigo. Good evening. Sorry, I was 5 minutes late. I was stuck in traffic. I think you two do not need any introduction for this seminar. I just want to stress that I just learned, this was new to me, Dr. Vigo, that you were the first in Italy to use IPL technology, and that you have established a center of excellence for dry eye. So this explains why the new features of the Sirius Plus are so interesting to you. And I would maybe like to ask you some of the questions that came in through the Q&A. And one of the questions goes to the first part of the talk to Dr. Carones, Francesco. Why should the ophthalmologist replace the old Sirius with the new Sirius Plus?
Well, first of all, Farhad, I'm so happy to see you. I'm a little bit bored to see you through a screen and with the wonderful Alps in the back. I hope to see you in the Alps, but not in the background.
Would be lovely.
And hopefully this is going to happen sooner or later. Well, the Sirius is a great instrument. It's a unique instrument that has been copied quite a lot by other companies. And the Sirius Plus actually really set the bar higher in the world of shunt cameras, because besides all the advantages that the Sirius used to give the ophthalmologist, now the Sirius Plus, as Luca already pointed out as well, can really be used as a tool, like a multitasking tool for tear film evaluation, for the complete ocular surface workup, and also for some information that you will request other instruments to obtain, like pupillometry. I like very much the dynamic pupillometry, because basically it is what we need when planning for surgery, especially for presbyopia correcting IOLs and so. So I really think that the advantages of the Sirius Plus justified investment of swapping the system. The new high resolution color camera gives different information. You can see the tear film, as Luca showed. You can see the lipid layer. You can really evaluate through fluorescein staining what's going on the surface. So I really think that it is a comprehensive tool that replaces the Sirius.
Thank you very much. And Dr. Vigo, from the perspective of the dry eye specialist, is there anything else you would like to add in terms of possibilities that the Sirius Plus now gives in dry eye assessment?
Yeah, I think that it's very, very important now to have an instrument that can detect any kind of dry eye disease and to make some diagnosis in this term. Because I think that the population that suffers from dry eye disease is very high, and so I think that if we have an instrument that is able to do almost everything that we need in terms of evaluation of anterior segment, but especially also evaluation of dry eye or of the tear film, is very important. Not only because we have a very important number of patients that suffer from dry eye, but also because in case of pre-op screening, to detect some patients that have some, tear film problems is very, very important, because sometimes we need to treat these patients before finishing the acquiring of the pre-op data. We have to treat this patient and asking the patient to come back once they have treated the problem related to dry eye, in order to have much better and precise data, pre-op data. And this is very important, not only because the patient will have better outcomes in terms of symptoms, but also in terms of precision of surgeries, and so better outcomes in terms also of refractive outcomes. And so this, I think, is very important. This instrument allows us to have all this data, and so I think that this is very important for us.
One more question, Dr. Vigo. If you do the IPL treatment with the several sessions, and you do a pre-op myography and the whole assessment, what is the time interval typically where you want to see the patient again at the Sirius Plus? Is it after the end of the third or fourth session, or later?
Usually, I want to check my patients after the complete treatment. That means after the third session, and I wait 1 month after the third session. That means I'm using the eSwim device, the IRPR, the EI device. We do three sessions, time 0, 15 days, and 45 days. And then, so I ask the patient to come back 1 month after the third. This is the timing.
Thank you. And one more question to Dr. Carones. is looking at Scheimpflug technology and knowing that CSO also is now spearheading the transition to anterior segment OCT placido-based topography. Is there still place for Scheimpflug technology in the era of the MS-39?
Well, Farhad, let me say that first of all, there is a price issue that makes a difference in between a Scheimpflug camera and an anterior segment OCT, at least as regards the CSO products. So the Sirius Plus is definitely cheaper than the OCT. And we all like the OCT because it gives many more details as regards the structures. But I still think that a Scheimpflug camera may be useful for those, for instance, not really doing surgery and being more on a clinical side, where you don't need all the information that the anterior segment OCT gives. I'm just figuring that optometrists, for instance, may save a lot of money having an instrument able to provide what they need as regards the ocular surface, as regards the details, as regards the anterior chamber depth, as regards contact lens fitting, all these things that you can do also with the MS-39, the anterior segment OCT from CSO, but again, at definitely higher cost.
Thank you very much, Francesco. There is one last question from the audience that might be directed to CSO directly. It's a practical question from Dr. Goraishi. Is it possible to upgrade our current series? Maybe somebody from CSO could answer this question.
Unfortunately, the system is completely redesigned, so it's not possible to have this upgrade. Sorry for this. So even if it's based on the same technology, the device is completely different, and the expensive part is not exchangeable. Probably what we're going to see is to provide some kind of exchange, but this is not in my end. Maybe salespeople can help on this. I would like
it would be nice to see like a swap. It would be nice to see like a swap program able to, support those who already have invested in the series and having some discount on the new platform.
Yeah. I'm not the right person to promote this, but I can guess that something like this will happen sooner or later.
I know we like to put you on the griddle, Francesco, so this is why.
I would like also to add something to the presentation of Francesco. Francesco highlighted the fact that Sirius Plus has much less scattering respect to the previous version, and in general respect to other Scheimpflug cameras. This effort on our side has a meaning. We are aiming, as you can imagine, to also to provide something for scleral lenses. And to do this, we need something that decreases a lot the amount of scattering, else the peripheral data won't be so accurate for a scleral lens fitting. That's why we invest time on decreasing the hyperreflectivity on the periphery.
Thank you very much, Francesco Versace. We have one last question, and then we should move on. It's from Dr. Fart. Is it possible to check tear film osmolarity by Sirius Plus systems?
No, it is not possible. You need another device, but there are two devices that are available in the market, on the market now. The one from Glaucoma and another one, and the small pen or the TLab is probably the most the well-known instrument. And but I think that in our practice we always check for osmolarity, because we think that also this value is very important in order to share patients in between dry eye patients and not dry eye patients, because I think this is a very important value. And but using the Sirius Plus is possible to use this value, to put this value in the software, and to have this value in the final report. And I think this is very important because you can get all this data in order to have the precise diagnosis that we aim So I think this, it is not possible to do this using the series plus, but it's possible to use the value inside the series plus.
Thank you very much, Dr. Vigo. And I think it's time to move to the second presentation, which is a pre-recorded presentation that I'm giving on CXL at the slit lamp, clinical experience and application. Thank you very much, Dr. Carones. Thank you very much, Dr. Vigo.
Thank you very much.
Thank you.
Bye.
Thank you.
Thanks, Francesco. Bye.
Bye.
Hi, this is Farhad Safezi from Zurich, Switzerland. My topic is cross-linking at the slit lamp, and I'm speaking to you in my function as the Chief Scientific and Medical Officer of Imagine. Some years ago, we developed a vision, which is taking out corneal cross-linking from the operating theater, which is expensive infrastructure, and placing it onto the slit lamp, which is the most simple common denominator we all share as eye doctors. After a few years of development, we finally came out with the CI device in 2020. And this small piece of equipment gives you a large choice of different protocols using intensities of 3, 9, 15, 18, and 30 milliwatts. It can provide you with pulsed and continuous light regimens. It has an optimized beam profile. You can perform multiple procedures with one single charge. You can even use a power bank to charge it if needed. And most importantly, besides the modern application at the slit lamp, you can also perform classic CXL in the laying position with the same device. Now, during the development process of this machine, we looked at potential obstacles. And the main obstacles that may be encountered are the time irradiation needs and the potential risk of infection. Let's look at time first. If you try to perform a Dresden protocol at the slit lamp, 30 minutes might indeed be too long, but we all know now that in epi-off cross-linking for keratoconus, in CXL, the 10-minute protocol, the slightly accelerated protocol, works very well. And in PAC cross-linking for infectious keratitis, we currently are at 4 minutes of treatment. And these irradiation times are feasible at the slit lamp without any major issues. You will see examples later. As for the risk of infection, if you look at any CXL or PAC CXL procedure, you never induce one only effect, you induce several effects. And these are biomechanical stiffening, steric hindrance, which means increased resistance to digestion, and then you stop replication by intercalating photoactivated riboflavin with DNA or RNA of anything that lives within the cornea. And lastly, you kill anything living in the cornea directly via oxidative stress. This happens in every cross-linking procedure, meaning that at the end of a CXL for keratoconus procedure with an open surface and epi-off, the cornea is sterile. So no need to mandatorily be in an operating theater. You can do this outside an operating theater too. And if you look at epi-on procedures without the open surface, the risk of infection is even more reduced. So these two issues and obstacles have been overcome. Let's have a look at the different protocols the device delivers. We have prepared a number of preset protocols to cover all modern aspects of CXL and PAC CXL. Let's go through them. Let's start with these protocols. These are protocols for epi-off cross-linking for keratoconus. As you can see, protocol 1 is the Dresden protocol. Protocol 2 is the slightly accelerated one. This is the fallback protocol that can be used in many cases of keratoconus treatment. Protocol 3 is more accelerated, might be suitable for less aggressive forms of keratoconus. And finally, there is a pulsed protocol that is used quite a bit in Italy with 15 milliwatts. All these protocols deliver a total fluence of 5.4 joule. Now, switching to protocol 4, which is for PAC cross-linking infection. This is a high fluence protocol, continuous light, 30 milliwatts per square meter, so very high intensity for 4 minutes. Remember that some years ago, we were able to show that oxygen is essential for cross-linking. This is true for keratoconus treatment, for biomechanics, so you cannot go too fast. But in the contrary, for PAC-CXL, and we also published on this, you can accelerate without losing efficacy. That's why 4 minutes are sufficient here, and that's the time you can easily spend at the slit lamp. Let's go back to CXL for keratoconus, this time epi-on protocols used with iontophoresis, no oxygen boost necessary, and the upper protocol is the one developed by Cosimo Mazzotta from Italy and is used quite extensively also. By the end of 2021, there will be one more update, which is an epi-on without the need for iontophoresis, so please watch out for future developments. And the latest addition to our protocols is the long-awaited treatment of ultra-thin corneas. You might have heard me speaking about cross-linking corneas of 250 microns or even thinner in the last years at various congresses. This was based on an algorithm that we developed and published back in 2017. This was a mathematical model, and then we went into a full clinical validation in a clinical study, which was just published a few days ago in the American Journal of Ophthalmology. That's the sub-400 protocol, and here you can treat down to 210 and even 200 microns of corneal stroma. So what you do is, when choosing this protocol, you apply the riboflavin, the RiboCare, for 10 minutes, and then measure thickness with ultrasound pachymetry. You get a minimal value, and this value you put into the machine. What is integrated in the machine is our published nomogram that then automatically chooses the right irradiation time and intensity for this thickness given. The CI device is the only cross-linking device on the market that has the sub-400 protocol integrated. How do you choose these protocols? Here's an example. It's very simple. Once you have switched on the device, you can move forward between the different protocols. Go back, and once you're happy with your choice, you press OK, and then UV, and you can perform the treatment. One very important feature is the fact that we can easily update future protocols via the USB port and a firmware update. So you are not stuck with these protocols. If in 2 years there will be an exciting new protocol coming out, the machines can be updated and adapted. Now, let's have a look at one of the very first slit lamp procedures performed in summer 2020. Let's revisit the start. First of all, I make the patient really comfortable. You see that I gave the patient my surgeon's chair with the armrest, and I check the height. Take a minute or two to make the patient really be comfortable. That's very important. Okay. The next step was, how can we, the next step is the simple irregular disinfection. I use chlorhexidine, and then I place the speculum that is contained in the CI procedure kit. It's a lightweight speculum that an open wire Kratz-Barra-Care that will not pull down your lids in the sitting position. Here it is. And now I have the patient come forward. The next step is very important. How do we remove the epithelium? Of course, we can do it with a scalpel or a hockey knife, which is not that easy in the sitting position, relatively easy for an experienced surgeon, but what about beginners? We came up, after more than a year of trying out, with this solution, which is tapping the corneal surface with a cotton bud that was before soaked in 40% ethanol. And what happens then is you just tap in a circular manner for roughly 70 seconds. You may want to refresh and take a second cotton bud after half of the time. And then after 70 seconds, see what happens with the epithelium. This is very reproducible. You can create a very nice 8 millimeter abrasure. Then rinse the eye in the vertical position. Tell the patient that a little bit of BSS will run down the cheek. That's no big deal. Here's the rinsing. All these videos are also on our website. We then take the patient into the semi-lying position, into a reclining chair, to apply the riboflavin for 10 minutes. 10 minutes are enough with RiboCare. Before doing so, we measure thickness using an ultrasound pachymeter, and we always have a pachymetric map printed out so we know where more or less to expect the thinnest point. And then, as I said, we start, that was oxybuprocaine, and then we start with the riboflavin. Every 2 minutes for 10 minutes. Do not forget to remeasure thickness at the end of the 10 minutes. We haven't shown this here because in case of a thin cornea, you will want to know where you are. Here, I'm scanning the tag of the riboflavin, and then I'm positioning the patient. You see the white cap that is on top of the machine. That is a barrier, a clean barrier between the eye and the machine. One last rinse off all the superfluous riboflavin, and then if you have a positioning light on your slit lamp, that comes in very handy because you give a target to the other eye, so you can very precisely position the patient's eye to be treated. I'm adjusting the diameter of the irradiation zone, which usually is around 9 millimeters, and here the machine is already counting down. As you can see, it also counts up the fluids from 0 to 5.4. And the patient is very steady. I'll show you examples afterwards. This is the view you have directly through the slit lamp. How do you find the right distance? Well, that's very easy. Before you switch on the UV light, you simply focus your image to the apex of the cornea, as you would do in any cornea assessment, and then you are exactly in the right distance. We recheck pachymetry, place a bandage lens, and this is it. Now, this was a CXL for keratoconus procedure. What are the particularities in PAC-CXL? Well, basically, you do not have to remove the entire epithelium. Simply use a dry sponge to remove the dead epithelium over the ulcer itself. Then use the high fluence profile for protocol and apply the riboflavin beforehand for 10 minutes over the epi-off region. And then the riboflavin will also penetrate horizontally over the other areas and then irradiate the entire cornea. That's important. So in fact, you're doing a partly epi-on, partly epi-off procedure. Now, a number of skepticisms have arisen, questions on the efficacy of the method in the sitting position. Let's have a look at them. The first is about the position itself. Many colleagues ask me, well, can you really perform cross-linking in the sitting position? Well, my answer is, why shouldn't we? Let's look at the factors that are needed for cross-linking. It's light, riboflavin, and oxygen. I think we all would agree that oxygen does not care whether the patient is sitting or lying, and light can be propagated horizontally and vertically, UV light, so that's no issue. The issue might be the riboflavin. If you sit, does the riboflavin gravitate downwards to the inferior cornea? Well, that's a legitimate question, and we have tested this and published some years ago. And the short answer is, do not worry about gravity. Why? Because you have 1 full hour before you can measure any relevant changes in riboflavin distribution between the upper and the lower cornea. It takes 60 minutes for the first few percent, 3.3% of difference in riboflavin distribution. So this is not really an issue. Another issue mentioned, or concern mentioned by colleagues, is fixation. Can patients really be at the slit lamp for so long? Please remember, 10 minutes for keratoconus treatment, roughly 4 minutes for PAC-CXL. Well, I have noted I've performed roughly 60 to 70 cross-linking procedures at the slit lamp in the past months, and I see that my patients are even calmer than in the laying position, because in the laying position I often ask them to raise the chin, so it's an unnatural head position, whereas in the sitting position they are comfortable and they have a fixation target on the other eye. So have a look at the video on the left. I will start the video now. And as you can see, the only reason you know the video is running is because of the flickering of the screen. The patient is absolutely stable in its fixation. Now the right eye, the right video, same thing here. And this is what we observe. You might have a microsaccade from time to time, but that's about it. The last issue is about is the patient comfortable enough to stay at the slit lamp? Well, we have interviewed every single patient since day one, and this is a typical response. Let me see whether you can hear it. Well, basically, now I don't have the sound here. I was asking the patient whether he was comfortable, and the patient's response was yes. The time spent at the slit lamp with some background music was easy and fixation was easy. So we had no issues here. And in the end, the patient was giving us a thumbs up. So yeah, I have to remember to switch on the sound here. Now, what does the future bring? If we look at CXL for keratoconus, then the future will be epi-on without additional oxygen. And this future is already here because you have the protocol 6, you can use it right away. How is this possible? Why don't we need an oxygen boost? Well, basically because an intelligent combination of factors allows you to overcome the limitation of oxygen diffusion. If you pulse the light alone, this will not do the job. If you increase fluence as the sole measure, it will not be sufficient. If you accelerate only gently, it's not enough. Iontophoresis alone is not efficient. But if you combine everything together, using normal air, no oxygen boost, then you will have a working protocol. And we call it an intelligent combination of factors. And this has been a protocol developed by Cosimo Mazzotta from Italy. And he just published in the JRS the 3-year clinical follow-up with really good results. That's the protocol that is integrated in the CI device. Now, as for cross-linking, PAC cross-linking for infectious keratitis, there are also some exciting news, which is we still have a lot of room for increasing efficacy. Most of the clinical results that you have seen in the past years were generated with the famous 5.4 joule that come from the original Dresden protocol. As you can see, using an efficacy of fluence of 5.4 joule, you have a relatively low efficacy in, let's say, bacterial killing. We published this in 2020. But if you increase the fluence to 10 and 15 joule, you reach virtually 100% of killing. And 15 joule is no science fiction. 15 joule has been already used and published in cross-linking procedures for keratoconus. So we can also use it in a more opaque and less transparent infectious cornea. Let me show you how the future of PAC cross-linking might look like. This is a patient with a severe fungal keratitis that had received 2 consecutive CSO treatments of 7.2 joule each within 48 hours. And as you can see, 8 weeks later, the cornea is quiescent and is scarred. It's a very nice example of how we can also treat fungal keratitis, but we have to increase fluence. One very important feature of the CI device is the amount of information that is available on the website. Please visit imagine-i.com, and as you will see, you have a list of all compatible slit lamps, but you also have abundant information on the protocols. If you have a look here, you can choose any protocol and get background information, including direct links to the respective citations, key citations. If you want to better understand the mechanism of action of PAC cross-linking, you will find a series of short videos explaining how does it work, why perform it, what are the clinical results, how to perform it, and which protocol to use. Or if you have questions and are a beginner with CXL at the slit lamp, you will find a series of short video sequences explaining every single step of the procedure. You will also find an abundant FAQ list of dozens of frequently asked questions around the procedure. The videos are subtitled in Italian, Spanish, and Chinese, more to come. And the entire website is translated in 13 different languages. Now, if you're looking for a distributor in your country, you will find the current list of distributors here. The list is constantly being enlarged and will be also enlarged substantially in the next weeks, but these are the current ones. If you are living in a country that is on this list, please contact your distributor. If you are not if your country is not on that list, you may proceed and order directly via Imagine's eShop in one of the languages of your choice. So that's the support we can give. Otherwise, please contact us directly via support@imagini.com. Now, in conclusion, we strongly believe that the CI device will democratize access to corneal cross-linking technology. And CXL at the slit lamp is suitable for all indications and all modern techniques. So in brief, CXL at the slit lamp is the future of cross-linking. Thank you for your attention.
So thank you very much. We have received a number of questions, and I think I will just go through the questions and discuss them directly. Can everybody hear me? Sometimes it's hard to look into a black screen, right? And you don't know whether the microphone is switched off or not. No, it seems to be okay. First question from Dr. Wehbe. Do you foresee an ultra-thin cornea protocol? And the answer is yes. As you may all know, we have established swelling of the cornea 12 years ago. That was the hyperosmolaric solution, but now we do better because we can adapt the fluence. This is something my research group has been working on for 5-6 years now. And just 2 weeks ago, we published our sub 400 protocol in the American Journal of Ophthalmology. And now you can use it. You can theoretically use it with any device, but it makes sense to do it at the slit lamp. And let me just share this screen with you and show you. Once again, it was in the presentation, but I have it here. You should be able. Can somebody from CSO Italia tell me whether you see the slide?
Yes, we can.
Thank you. This was one of the slides I showed. And as you can see here, the sub 400 protocol will be integrated as a software upgrade of the CI device. So you currently have the 7 protocols, and in roughly 3 to 4 weeks, you will receive a firmware upgrade, those who already have a machine, and then you can perform the sub 400 protocol with the CI device. The thinnest corneas I have treated so far were 210 microns of stroma. The success rate of the protocol is surprisingly high, 89% with a follow-up of 1 year. And we have validated this over 4 years in total. So in the future, you will have a way to perform very far advanced cases safely at the slit lamp. On Saturday, I will present the first cases of keratoglobus treated with cross-linking using the sub 400 protocol. Let's go to the next question. But before I do this, something very important I forgot to mention, which is the Imagine has found the ideal partner to develop and produce the CI device, which is CSO Italia. And this is the reason why Imagine is giving this talk here today in CSO webinar as a guest of CSO. And we are very happy to have such a partner with a long-standing tradition and expertise in the field of device manufacturing and ophthalmology. Then the next question, doesn't the fixation eye become dry and has to blink? Usually not. We didn't observe this. The treatment times go from 4 to 10 minutes. The other eye with the fixation target can blink normally. If they don't squeeze, they can do some blinking movements without problem. We never had an issue there. Then on which bacterial strains responsible for keratitis has the PAC cross-linking protocol shown the best efficacy? That's from Dr. Ussi. We have tested the data we published was on the strains that play the biggest role in keratitis, which is MRSA, so multi-resistant Staph aureus, Staph epidermidis, and Pseudomonas. And there, with high fluence, we had killing rates of up to 98%. And another question from Dr. Ussi, PAC cross-linking for acanthamoeba. For now, we have limited results in acanthamoeba because these cysts are very hard to open and to kill. We need much higher fluences, and we are currently, us and others are working on higher fluences in PAC cross-linking. We're going to 10 and even 15 joule, as you have seen. Then the next question is, do you have any experience using riboflavin and HPMC every minute for 10 minutes for corneal saturation in sitting position? Well, you've seen the video. We do the saturation in the semi-lying position. We take the patient from the slit lamp into a reclining chair, and HPMC is a carrier. You do not necessarily need HPMC in a riboflavin solution, and we did not include HPMC in our RiboCare. Why? Because we wanted to create one riboflavin that is good for both epi-on and epi-off solutions. And HPMC is not ideal if you go into epi-on. So we don't have that issue, and we have checked with multi-photon experiments at the University of Zurich that after 10 minutes already, we reach a steady state of riboflavin concentration in the cornea. The next question is, how long do you recommend? What is your recommendation about alcohol concentration and time for epithelial removal? We tried this for some months to get to the best concentration. It is 40% ethanol, and you tap for 70 seconds, and then you will have no problem removing the epithelium. I use a wooden cotton bud, which is drenched in alcohol, and after 35 seconds, I take a second fresh one. Something very important, if you have a bottle of 40% ethanol, do not open the bottle 20 minutes before you start, because the alcohol will just evaporate. You need to open that bottle 20 seconds, your assistant, 20 seconds before you remove. So very fresh, pour a little bit into a container and moisten. And then you will have very nice results. How long do you recommend riboflavin drop instillation? This I just mentioned, 10 minutes is enough to reach a steady state. Then there is a question about the M protocol. And the M protocol, I just have to see, can you still all hear me? Because I don't see myself anymore. I see the CSO Italia sign. CSO Italia, is everything okay still?
Yes,
Hello?
we can see you.
Thank you. So briefly, my friend Cosimo Mazzotta has published on the M protocol 2 years ago. What is the difference between the M protocol and the sub 400? The M protocol is not based on an algorithm. The M protocol is a collection of all the data from solid studies that have been published over the past years using different fluences, different irradiation times with reported depth of treatment. So it's like a collection of published clinical data, and it says, if you want to treat to 240 micron, then use the fluence from this publication using 30 milliwatts pulse light in iontophoresis and so on, or you need 15 milliwatts in pulse light or 9 milliwatts in continuous. It's a collection. The sub 400 is all based on 3 milliwatts and reducing the fluence. I think you can do thin corneas with both protocols, but if you use the M protocol, you need a very sophisticated device that delivers everything. And I like simple. Simple means I wanted to give this into the hands of the entire world, into somebody who has a 10-year-old machine that can only do 3 milliwatts. The CI device can do it all, but still we want to keep it simple, and it's an algorithm that we adapted. It's not a collection of protocols. The next question is from Dr. Hashemian. Where do I find this table? It's published 2 weeks ago, American Journal of Ophthalmology, Hafezi et al. You will find it in the January edition of the AJO. Is it available on the website? Yes, it is available on the website of the Light for Sight Foundation. lightforsight.org. We have the preprint of the AJO, which we can distribute freely, and you have the table in there. I'm almost through. Don't you put any additional riboflavin during CI UV exposure? And now I have to briefly grab urgently, I'm very sorry, I have to grab a power adapter or I will run out of battery. I'm very sorry, stay with me.
Okay, I think in the meantime, we can proceed with the next presentation by Dr. Rawad. OCT in keratoconus diagnosis and treatment of keratoconus.
Hello, everybody. What is the role of OCT in the diagnosis and treatment of keratoconus? Current advances have recently allowed for the incorporation of anterior segment OCT in routine corneal tomography systems, allowing for segmental tomography, imaging the cornea and the anterior segment as sophisticated slit lamps, while still performing traditional corneal tomography. And this also makes it a valuable tool for the surgical treatment of keratoconus, whether cross-linking or combined with custom laser treatments or other forms of treatments. This technology is invaluable even in following postoperative patients. Hence, we need to rewire our brains to adapt to the new possibilities these machines offer. The first being that these platforms, notably the MS-39, represent a super slit lamp tool letting you see and quantitate the smallest hidden details, such as stromal haze, demarcation line, and corneal ring segment depth, as well as scleral spur to scleral spur distance and lens rise for keratoconus eyes needing toric phakic intraocular lenses. Even the slightest anatomical landmarks can be picked up. This eye has had cross-linking and the patient is seeking second opinion. Did the patient undergo PTK or PRK with cross-linking or cross-linking alone? A closer look allows to locate the bilaminar Bowman's layer. Hence, it is intact in here, which means the patient did not have any previous surface ablation, whether PTK or PRK. Now, locating shallower demarcation lines are easy as keratocytes are more populous in the anterior stroma. But deeper ones are more tricky, less hazy and less conspicuous. But with high definition OCT technology and low noise, it is easy to locate them and determine their depth. This is a corneal OCT of a patient with deep corneal ring segment implantation causing perforation and edema. OCT with the MS39 confirmed the diagnosis. And after removal, allowed for proper measurement of overlying safe stroma for the placement of CARES allogenic segment at 250 microns depth. And this resulted in a whopping improvement in topography after the perforating ring segment was exchanged for CARES at 250 microns depth. Now, other than acting as a super powerful and digital slit lamps, OCT technology allows for an even better traditional tomography. It often delivers better pachymetry readings. This is a post-cross-linking eye with haze. Scheimpflug tomography shows much more thinning than OCT does, and hence the importance of having OCT to plan for custom surface ablation in a post-cross-linking eye. We have compared these two technologies, post-cross-linking, in an article in AJO and compared it with ultrasound as well. OCT displays a better posterior fluid. Any haze or scar in the cornea can lead to an underlying artifact in the BFS. Here we see a focal elevation on Scheimpflug that is absent on OCT. OCT provides a better posterior curvature representation with higher resolution and less scatter. In this example, where the BFS is asymmetrical, we know it is due to a large angle alpha and not keratoconus, as the posterior curvature is perfectly symmetrical and we can see a very nice posterior bow tie. Now, looking at the epithelial maps can also further confirm the assessment. This is a hexa map from the MS39. And comparing anterior and posterior tangential curvature maps, the anterior shows inferior steepening while the posterior shows a more or less regular bow tie. The epithelial map shows a thickening inferiorly, which is responsible for the inferior steepening on the anterior curvature, and corroborates the assessment that this is not an ectasia. Now, OCT is especially helpful in the surgical planning. This is a post-corneal ring segment eye that is planned for PTK and cross-linking. Now, looking at the epithelial map, the epithelium thickness is 42 microns at the cone, 48 microns at the corneal apex, and 55 microns at the pupil center. It gives the surgeon a clear idea about the amount of stromal shaving at the cone if PTK is performed, whether centered on the corneal vertex, pupil center, or on the cone, such as in the case of TREC. Now, a better posterior curvature measurement leads to a better posterior aberration measurement. This eye underwent corneal wavefront-guided PRK and cross-linking with minimal tissue ablation to just tackle the coma. And it shows regularization and flattening of the cone postoperatively. Now, the total corneal aberrations were computed thanks to accurate OCT assessment of the posterior curvature, and an optical quality summary could be derived using the total corneal higher order aberration and not just the anterior corneal one. And it shows a marked improvement on all spatial frequencies postoperatively. Now, I would like to finish by a case presentation that would highlight the importance of posterior curvature aberrations in the assessment and management of the keratoconus patient. This is a post-cross-linking eye with moderate anterior haze, as can be seen on slit lamp and OCT section. This is the hexa map showing the anterior and posterior tangential curvature. Bear in mind that the posterior curvature coma negates the anterior curvature coma by about 30 to 40% on the average in keratoconus, as has been shown and published by Bruce Allen a couple years ago in JCRS. This is the total corneal aberrations display on the MS-39. A segmental assessment of the total corneal aberrations shows that the anterior coma here, 0.86 diopter at 100, is partially offset by the posterior coma, 0.41 at 85, 180 degrees away, to yield a total corneal coma of 0.43 and 97, hence a 50% offset. Hence, treating only anterior coma would uncover the posterior coma, and the final result would still be 0.4 diopter, but 180 degrees away, hence 0.4 at 285, which makes it that we haven't done anything for the patient. Pyramidal ocular wavefront measurement using the Paramus or Osiris confirmed the same total ocular coma values of around 0.4 diopter at 92. Hence, ocular wavefront PRK was performed instead of anterior corneal wavefront guided or topography guided PRK in order to treat the total corneal coma, which was equivalent in this case to the ocular coma. Postoperatively, you can tell that the anterior curvature improved but is still showing asymmetry, and hence anterior corneal aberration can be seen. But looking at segmental aberrations, there is still 0.4 diopter at 103 of anterior coma, but the total coma is 0, because the posterior coma is still 0.4 at 283, offsetting the anterior one. So here the aim is not to treat the anterior curvature, but the total curvature or the total aberrations. And hence, OCT-driven total corneal wavefront treatment is the way to go in keratoconus treatment and will be soon available thanks to OCT technology. So in conclusion, the three vital features that make OCT tomography a game changer in keratoconus management are OCT sections, epithelial maps, and posterior curvature with derived higher order aberrations. Thank you.
Thank you very much, Professor Awad. And my apologies, I was thinking that a laptop can run without electricity. So I had to start spurting through the house looking for the charger. I'm very happy to see you tonight, Shadi. And I couldn't listen to part of it because I was busy with the technical setup, but I've seen what you are able to do with the CSO's technology, and my best allegory is this: these devices can be driven like Volkswagen Golf, or you can take them as a Ferrari and really tune everything out of them and get so much information that many of us would in daily life not even know the machine is capable of. So you really show the full potential of that technology.
Thank you, Ferry. Thanks a lot. This is so true. Yeah.
I'm looking at questions. One question from Dr. Flores, Shadi, is what about Gaussian maps?
Yeah, actually, Gaussian maps are really interesting, and I don't know if one would look at a tangential map and compare it at a axial map, and you can tell that to locate the cone of the read cone in keratoconus, you should look at instantaneous or tangential and not at axial, because axial always smooth out the surfaces and actually let the cone look like it's all over and more at the periphery where the cone is actually pretty much more towards the center. Gaussian map takes it a notch further. It can locate the true power of the cornea and not just, the way it looks at the tangential. So when I look at axial, I can see a blurred image possible of the cone. Instantaneous, I can locate the cone more. Gaussian would kind of give me exactly what that cone is. So for instance, if you look at the epithelial maps, look at the Gaussian, I always see they are more superimposed than when I looked at instantaneous and then I look at the epithelial map. So that's one more thing. If one would care about treating with PTK or doing TREC, like we've seen TREC from Rohit Shetty, I would actually look at Gaussian map as well. We're just not used still to understand Gaussian map, so we like always to look at the time-honored instantaneous curvature. So I always look at both, and I'm kind of more and more getting used at the Gaussian map as well.
Thank you very much, Shadi. And one last question. Just a very few days ago, you published a really nice paper in the JRS on why we should avoid using mitomycin after cross-linking. This is all haze related. How do you deal with post-op haze after surface ablation, having a Scheimpflug system and the MS-39 at disposition?
Yeah. Basically, again, the Scheimpflug is has a lot of, is affected by scatter. And with haze, you can't really follow up corneal thickness. You've shown a very interesting case before, how you could go completely astray looking at the posterior surface and thinking you have an ectasia or you have some irregularities, or even the higher order aberration will be wrongly interpreted. That's why, especially in cases with cross-linking, where haze is the norm, depends whether it's mild haze, minimal haze, or more advanced haze. I want a OCT device that would kind of be more immune to haze to give me the posterior curvature. The case that I showed right now was a case treated with cross-linking before, and we wanted to operate on him. And there's no way we could decide about the value of the posterior curvature with a Scheimpflug device. With an OCT device, we could tell that the posterior curvature were negating the anterior curvature, and we decided to proceed with octal waveform guided. That's thanks to the OCT technology.
Thank you. And there is one more question I think that is interesting for many amongst us. Is it possible to perform transepithelial surface ablation thanks to epithelial maps from the MS-39?
Yes, this is very tricky because yes, we can, and it's pretty accurate. One more thing we need to bear in mind, however, is that the MS-39 reports the epithelium as perpendicular or normal to the surface of Bowman's layer or the surface of the stroma. Whereas when we plug that in the laser takes it as a normal, as vertical to the corneal surface. So when we look at the very center, yes, the values from the MS-39 are exactly the values the laser we should plug in the laser. At the very periphery, that changes because the MS-39 displays the values at perpendicular to the stroma, whereas the laser calculates these values as vertical. So there is a difference. We have published a paper with Sam Arba-Mosquera from Schwind about the relationship between the two. And I'm aware that soon enough, there will be a kind of automatic transition whereas you just get the MS-39 and then it will be translated automatically. So right now there is an algorithm. It is available in that paper in JRS about, I guess, 8 months ago, but definitely the center can be extrapolated. If the doctor is in doubt, as long as it's not a very abnormal cornea, let's say if it's a regular cornea, then I would just plug in the center and let the laser does the transition. If it's an abnormal cornea, like in keratoconus, then the doctor needs to understand the difference between the two. Yeah.
Thank you, Professor Awad. And Shadi, there is one more question from Dr. Flores. Do you use the stromal elevation map of the MS-39?
I think this is very interesting, but personally, I don't use it yet. Yeah, because I don't see a reason why I would use it right now.
And now we have 4 questions from Dr. Hashemi, and they all turn around the same thing. He has seen clinically that the Athens protocol might give him severe haze. So he has a number of questions around the sense in doing simultaneous CXL and PRK treatments, whether you do it, whether it makes sense to treat simultaneously.
Yeah, I mean, again, if you look at the Athens protocol, mitomycin was used for 20 seconds. Another study by Marconi Santiago, where they used mitomycin for 30 up to 40 seconds, they even had a lot of haze. So technically, most of the haze in combined treatment for me is from mitomycin C. We definitely have more haze when we combine them, and when I followed my patient, the peak of the haze is actually between 1 month and 3 months, not in the first month. So it's typically about 6 weeks to 3 months. And this is where I keep the steroid. I get the patient to be followed every month to make sure that they're clear. And most importantly, I don't use mitomycin C. The second trick is that as opposed to the Athens protocol, I use the least ablation possible. So that's why I think there is a difference from Athens. The Athens protocol uses usually 5 millimeter, actually all the 6.5 or 7 millimeter, and stick to the higher order aberrations.
Thank you. And the last question from Thierry Babralati, how important do you think epithelial mapping is for keratoconus?
I mean, it's very important because there is a case, an interesting case that I actually did a couple of weeks ago, whereby I was about to treat with corneal wavefront guided or topography guided, and I looked at the epithelium and I saw that the cone was a little bit displaced and the epithelium was really thin over the cone. If I went, if I went with transepithelial topography guided, I would have actually ablated way too much on the cone. So what I did is actually a pure PTK, because I knew that it was about 15 micron. And actually what I actually exactly predicted by. So for me, yes, it is vital. I didn't do much anything at the epithelial keratoconus.
Thank you very much. I think we had a little bit of transmission problems, but I think we all heard the answer sufficiently well. We have had a lot of questions, and let me see. We answered about 10 questions in this last talk, which is awesome. Nothing open anymore, so I think it is time to hand over the microphone back to CSO Italia. Thank you very much for the organization. Thank you, Dr. Carones, Dr. Vida, Professor Awad, for being with us. And I would like to hand over back to Francesco Versace. Thank you.
Yeah, on behalf of CSO, I would like to thank you for being here with us. And I would like also to thank all the attendees today. Have a good night and see you next time. Bye-bye.